Good morning, everybody. Welcome back to the Department of Medicine Grand Rounds. Today we're excited to have our own Dr. Tarek Alhamad. Dr. Alhamad completed his medical degree at the University of Damascus in Syria, followed by residency at Paul Foster School of Medicine, a branch of Texas Tech University in El Paso, Texas. Afterwards, he completed his nephrology fellowship and obtained a master's in public health science at Penn State University, followed by a transplant nephrology fellowship at the Mayo Clinic in Scottsdale, Arizona, before he finally joined us in 2014 as faculty. The main goal of his career is to, and quotes, prolong the survival of kidney transplant as long as possible. More specifically, he's focused on investigating the mechanisms of identifying better monitoring tools for, and ultimately, improving treatment of allograft rejection. As one example of the work he's done, he's explored how cell-free DNA can serve as a marker of early allograft injury prior to the development of overt graft injury, potentially leading to more aggressive and earlier interventions to prolong allograft function. Since joining us, he has risen the ranks and is now the medical director of kidney transplant and pancreas transplant programs. Today, he'll be talking about ways to expand the kidney donor pool and find ways to bring this life-saving treatment to more patients who need it. Please help me welcome Dr. Alhamad to our Grand Rounds.
Good morning. Thanks for the kind introduction. Appreciate the opportunity to speak today. Let me just get this here. This is one of the slides that I have to include in my presentation about my disclosures. Majority of them are actually more like clinical trials, but nothing related to this topic. So as you know, hemodialysis is a life-saving treatment. Patients with advanced kidney disease, they will expire in short period of time without getting hemodialysis. However, hemodialysis have certain issues. The first one, that this dialysis comes with decreased survival. The patient don't survive that long in hemodialysis. Comes with poor quality of life, high rate of depression. So there's nothing better than actually our own kidneys, nothing better than a kidney, a native kidney. Earlier studies have shown that kidney transplant provides better survival compared to hemodialysis. This is back in 1983, and we could see that the y-axis is the survival probability, and we could see dialysis at the lower of that curve, whether it was living-related or cadaveric. Kidney transplant provides longer survival for patients with advanced kidney disease. This has been done in other multiple studies compared to all types of hemodialysis: peritoneal dialysis, home hemodialysis. Kidney transplants provide better survival. Here, it took around 3 months to get to equal survival, and then we can see the improved survival of kidney transplant compared to staying on hemodialysis. The benefits around 70% less risk of death compared to dialysis. So overall, the benefits of kidney transplant: patients live longer, better quality of life, no need to be attached to the machine 3 days a week, more energy, more ability to travel, more ability to go back to your education, no restrictions for what you could eat, and improve fertility and improves, especially for women, the ability to conceive. So with all these benefits, transplant become the treatment, the golden option for patients on hemodialysis. The number of kidney transplants have been increased over time. Here in the y-axis, we have the number of transplants. Here are the years, and we could see that the number of deceased donor kidney transplant has increased in the last couple of years, reaching around 20,000. Living has not increased much. We could talk more about it if there's an interest for that. At the same time, the number of newly waitlisted for kidney transplant has increased. So in the last few years, despite the increase of the number of transplants, there are more patients waiting, more newly patients are waiting on the list. So how's the balance now? The balance that there are still around 150,000 patients waiting for kidney transplant. Let's look at 2024. In 2024, we have 27,000 kidney transplants that was performed, 49,000 newly waitlisted. So the message that I'm trying to show you here as an introduction for my presentation, that we have severe shortage of organs. We don't have enough organs to provide for patients who are on hemodialysis. Let's take one more study here before we get into the topic. This represents what's happening after 3 years of being on the waiting list. So here we have the y-axis percentage, and we have different lines here. So at 3 years from being on the wait list, around 40% of patients are still waiting for kidney transplant. Around 10% died. 20% removed from the list, most likely being sick, comorbidities that they are not anymore eligible for kidney transplantation. And you could see that the number of who got kidney transplants probably around 40%. So we are not doing that great by providing opportunities for these patients to get a kidney. So in this presentation, I will talk about some non-ideal kidneys that we could consider as options for patients on hemodialysis. And I will talk about each option and we'll show a couple of studies for each type of kidneys, and probably we'll spend more time on the hep C donors as a type of non-ideal kidneys that we have been considering here in our center. So the non-ideal kidney that was started many years ago, that was called expanded kidney donor, and you need to have either the donor is more than 60 or the donor more than 50 with a couple of factors, either hypertension, CVA, or creatinine more than 1.5. The issue with that classification, it's a binary classification. So either you say that this kidney is extended or this kidney is standard. And many of these kidneys that they were labeled extended, they have very good survival. So they moved to more like a continuous number. So with a number from 0 to 100. And they included 10 factors from the donor, including age, BMI, race, hypertension, diabetes, CVA as a cause of death, creatinine for the donor, hep C, and this donation after cardiac death. We are talking about 10 factors for donor. And based on the score, we're going to classify the donors based on that number. I'm going to highlight here a couple of factors, and I will come back later to see if you would agree about removing that factor from that model. So based on the score, kidney donor profile index, which included 10 factors, 10 donor factors, we have very good kidneys with a KDPI less than 20%. We have an average kidney with a score of 20 to 85%. And we have non-ideal kidney with a KDPI more than 85%. Now, these type of kidneys require special consent from the patient. The patient must be aware that this kidney gonna last less than the average standard kidney. The average deceased kidney lasts for 10 to 12 years. This KDPI will last for around 7 years. But it could be a good option for certain type of patients. What are the outcomes of these kidneys who have KDPI more than 85%? So going back to the graft survival here, we have the same figure that we showed earlier. Here we have the y-axis cumulative mortality ratio. We have the red line equals survival, and we have divided the KDPI into 3 categories. The first one, 70 to 80% have better, so the lower means the better survival. So here we have improved survival compared to staying on hemodialysis. And we have here the other type, which is have the higher numbers, KDPI 90 to 100. So they are still better than hemodialysis in terms of patient survival. It takes longer time to have that equal survival, around 1.5 years, but these kidneys actually still have being better option than dialysis. The high KDPI kidneys oftenly discard. We are looking here at the KDPI more than 85%. At the gray line, we could see that the discard goes up as the KDPI goes up, and it gets around 60% of kidneys with high KDPI being discarded. Their survival is not that bad. Graft survival at 5 years is 70% for the KDPI, more than 85%. So it could be a valuable option for certain patients. So who do we offer high KDPI in our center? We offer high KDPI for patients who are more than 65. And last year, we were the second largest center that offered transplants for elderly patients who are more than 65. We offer them for patients with multiple comorbidities, and we think that they are sort of like marginal candidates for transplantation to start with. And we need to provide them with a kidney that gets them away from hemodialysis. Patients who cannot wait 3 to 5 years on dialysis. Yesterday, I have a discussion with a patient who has liver cirrhosis, not advanced, without portal hypertension, and he basically wants to just get away from dialysis for 3 to 5 years. We discussed about the graft survival and the impact of cirrhosis on his kidneys, and he basically said, I will take any kidney. I just want to be off dialysis for a few years. So for those type of patients, we may consider offering high KDPI. It needs a special consent that they are aware that this kidney is not going to last as long as standard kidney. Moving to the second part of organs that we could consider, called socially high-risk kidneys. Those are kidneys have very good function, coming usually from young donors. They have been labeled as socially high risk. I will give you a second here to look at the criteria, but basically having money for sex, being in prison, having high risk for having HCV, HIV, and HPV. Those kidneys actually are very, very good quality. Unfortunately, it's being often discarded just being by labeled socially high-risk kidneys. This is one of the study that showed their outcome. Socially high-risk, CDC high-risk is in the green line, and you could see that they perform and sometimes a little bit better than the standard kidneys. Why? Because usually they are coming from young donors. Studies have shown that if you decline the kidney offer from socially high-risk donors, the chances of mortality will be higher. So here in the left figure here, cumulative mortality, we have two lines. The one is declined kidney offer and one who accepted kidney offer. And you could see high mortality for patients who declined the offer. Declining the offer, to get another offer, it may take a week or 2 weeks, but it may take also 6 to 12 months, may take a couple of years, depends when you are positioned on your waiting list and depends with the matching of that donor that happened. So does not mean if you're getting an offer that you're going to get an offer immediately in the following month. Subsequent 5 years after declining a kidney from a donor with the presence of risk factors of HIV, hepatitis B, and HCV, 40% died or removed from the waiting list. Those are the patients who denied accepting a kidney from a socially high-risk donor. 15.5% remained on the waiting list, and only a third of them got a kidney transplant without risk factors. So these are quite shocking number. The risk of getting infections or risk of transmissions of disease from these donors are quite low. It's 0.4 out of 100, which is lower than the risk of dying from a car accident. So it's very, very low risk. We have done tons of these kidneys, and we have 0 case of transmission of disease. Any questions? All right. Let's move to more a harder topic about getting kidneys from donors with hepatitis C. Donors with hepatitis C viremia, the chance of getting the virus transmitted to the recipient is 100%. So if we are getting a kidney from a donor with hep C, we know for sure that the recipient will get hep C and he will require treatment with the DAA for 12 weeks. Before I start this section, just want to see from your side, if you have a patient being on dialysis, would you encourage him to get a kidney from a hep C donor? Dr. Fraser supports this. Few hands here. Great. Okay. So let's talk about the hep C and what are the outcomes of these kidneys. Now, previously, hep C, before the DAA therapy, direct antiviral therapy, the main medication for treatment was interferon. And interferon indirectly antiviral mechanism, modulating an immune response against hepatocyte infected with hep C. However, there are issues with interferon. Mainly for the kidney, we're talking about the kidney, increased kidney injury, increased the risk of rejection, and increased the type of rejection that is resistant to steroids, associated with the graft loss and high rate of relapse with the hep C in the recipients. So those kidneys for a long time, they have not been utilized with high rate of discard. Only they have been given for patients who have hep C. So hep C donor to hep C recipient, or for recipients who are willing to try this kind of donors, of kidneys. Interferon therapy has been shown to increase the risk of rejection, and this have been different theories about the exact mechanism. One of them is by increasing the expression of HLA class 1, class 2, and also by activating the T cell and CNI interferon production. As you recall, the KDPI, one of the factors with the donor was hep C. So based on the outcomes of hep C donors, the hep C was part of the KDPI and increased the KDPI, which is Kidney Donor Profile Index. Remember that score, the lower the better. So the higher the score, it comes with the non-ideal kidneys. So having a donor with hep C, that will inflate the KDPI by 20%. And as you recall, with the KDPI more than 85%, we need a special consent. And that leads to more discard of these kidneys. Now, the DAA therapy came and changed the field of treatment with hep C. It was started back in 2014 and have not been examined in kidney transplantation till around 2019. It comes with minimal side effects, with effectiveness close probably to 97-98%. Sorry, this is a duplicate slide. So in 2019, there were two main papers that came in the field of transplant, the Thinker study and the Expand study. Both showed, small number of patients, both showed that hep C could be treated and eradicated post-transplant, and none of these patients who got a kidney from a donor with hep C got liver disease. So let's take these two studies quickly here. This is the Thinker study, 12-month outcomes after treatment with hep C. It included 20 patients. They started treatment on post-operation day 3 for 12 weeks. All these 20 patients, they have hep C cure with a good quality of kidneys, and the GFR was comparable at 12 months. The other study, the Expand study, included 10 transplant recipients. They got treated prior to transplant, 12 to 16 weeks of therapy, and no adverse events, with no hep C viremia being detected after the 12 week of therapy. So based on these results, centers start exploring utilizing these kidneys in the real life transplant without performing trials. There have been two other studies looking at shorten the therapy of the hep C. Do we have to give 12-week therapy, or could we shorten that by few weeks? So the ultra short duration direct DAA was given as prophylactic. So they gave here 3 days of therapy instead of 12 weeks, but they started post-operation day 1, and the second group here, they gave 2 more doses on post-operation day 2 and post-operation day 3. So group 1, 1 dose pre-transplant and 1 dose post-transplant. Group 2, they have 2 more doses on day 2 and 3. The idea, let's see if they could shorten and prevent the Hep C transmission by giving DAA before the actual transmission. The GFR between the groups were similar. However, there was an issue here that there was some relapse and some resistance in these cases. So here, if we take patient number 3, so at week 14, we have a rise of Hep C viral load. We have another patient here, for example, patient number 9, after treatment have a rebound of Hep C. So the outcomes, they have some cases of resistance. We have cases of occurrence of Hep C viremia 12 or 14 weeks after kidney transplantation. Same group tried a longer therapy, not 3 days, but they said let's do a 7-day therapy. So outcomes of 7-day therapy here, 50 patients, and they were able to decrease the transmission rate from 100 to 4% by giving 7-day therapy. One issue comes here that when we are providing this therapy at the time of transplant, the insurance will not approve this therapy until you have a documentation that there's a Hep C viremia. So starting early, pre or post-operation day 1, have some limitation. So we did a survey of clinicians taking their opinion on kidney transplantations from donors with Hep C. This was mainly for transplant providers, and the main concern that came from the transplant providers that they were unsure about insurance coverage for DAA therapy. So that was the main limitation for not using these kidneys. The second concern was the fear of high DAA cost to the program. Other less concern about transmission and the therapy of 12 weeks. Here in WashU and Barnes Transplant Center, it took us probably a year and a half to be able to start the program. And the main concern that if the insurance is not covering the Hep C treatment, who's going to cover the therapy? And we were able to have a certain arrangement with Barnes that if the insurance is refusing to cover, Barnes will be able to cover the DAA therapy for 12 weeks for the recipients. So we started that, and many other transplant centers have been doing Hep C. So let's look at the discard of these organs over the last few years. So we did that study from 2005 to 2019, looking at utilization and discard of kidneys from donors with Hep C. 5% were from Hep C seropositive donors. This is the initial figure here to show the number of patients, but basically we have 4.8% from donors who are seropositive. We call them seropositive kidneys, and 93% from seronegative kidneys. And then at the later, after 2015, we were able to look at that data, and we were able to distinguish between viremic, Hep C NAT positive, and aviremic, antibody positive, NAT negative, and we compared them to aviremic seropositive compared to aviremic seronegative. This is table 1, but I'm just going to highlight some of these factors here. We have here the viremic kidneys, or to be more accurate, kidneys from viremic donors. Let's call them viremic kidneys. And these kidneys, if we compare them to seronegative donors, we could see that they are less likely to be elderly. They are less likely to be African American, the donors. They are less likely to have diabetes, less likely to have hypertension. We'll continue with the baseline characteristics. less likely to have high KDPI more than 85%. For example, here was 11% compared to 15% from seronegative donors. Less likely to die from a stroke. Despite that, they were more likely to be discarded. So despite all the favorable characteristics, these kidneys were more likely to be discarded. This is multivariate adjusted odds ratio of discard. And we could see that with the starting of DAA therapy, that the discard ratio is going down, still significant at 20% in 2019. When we look at the three groups and we categorize the donors based off viremic, aviremic, we could see that aviremic kidneys in the red squares, they are not have any more higher discard of higher ratio of discard, whereas viremic kidneys continues to have 48% higher risk of discard. The risk of discard is varies based on the UNOS region. So the United States is divided into 12 to 11 regions, and the ratio of discarded viremic kidneys varies between the region and their waiting time for kidneys. Let's look at the long-term outcome of these kidneys. We talked about 1 year survival, we talked about 1 year GFR, but how about 3 years from transplanting these kidneys? How good they are? We looked at the outcomes from 2015 to 2021. We have now 2,300 viremic kidneys. We're going to compare them to 63 aviremic kidneys, seronegative kidneys. Now we'll talk about the recipient characteristics here. We'll go quickly over these factors. The age for, let me just highlight that here. So here, just to orient you here, these are NAT positive, these are viremic kidneys. And we could see that the recipient here, a little bit older, more likely to be African American, more likely to have high BMI, more than 30. So we are talking about recipients who have a little bit more risk factors. And compared to the same quality of kidneys before that we reviewed in the prior studies, these kidneys have overall from younger donors, less likely to be African American, less diabetes, hypertension, and less cause of death compared to antibody negative, NAT negative. In the biopsies, these kidneys have 49% with almost no glomerulosclerosis. So very good kidneys in quality. So if we look at overall the balance here, recipients have more risk factors, donors have favorable characteristics of these kidneys, and we look at the outcomes. Here we have years of follow-up after kidney transplantation. We have the first group, antibody negative, NAT negative. We're going to look at this other control group. We'll look at aviremic kidneys, anti-positive, NAT negative. We see no increased risk of graft failure at 1, 2, 3 years, regardless of how we did the analysis and adjusted, weighted and adjusted, and sensitivity analysis. No increased risk of graft failure for aviremic kidneys and viremic kidneys. So overall, to sum up, these kidneys are safe, no change in difference in outcomes, and no difference of GFR at 1 year of transplant. This is the same information, just showing to you in a Kaplan-Meier survivor curve that kidneys from Hep C viremic donors have similar outcomes. So to sum up, what are the benefits? We have shorter waiting time. So if you accept a kidney from Hep C, you are saving a couple of years on the waiting time for a kidney transplant. No issues so far in our center or other centers actually about insurance coverage. Good donor characteristics. These are very good quality of kidneys and will provide really very good outcomes. In terms of cost effectiveness, and before I move to that point, just want to report here that overall this DAA therapy reduced the risk of death by around 57% compared to the prior to DAA therapy. In terms of cost effectiveness, we could see that if you're waiting less than 3 years, then it's cost effectiveness for the center and for the overall system to accept these kidneys from Hep C donors. Our current practice at our program, if the donor is Hep C antibody positive, the transmission without viremia, the transmission is very low. We follow up with checking PCR at certain time intervals. If the Hep C NAT positive viremic, then we know that the transmission is almost 100%. We start treatment within a couple of weeks after viremia. We aim to start before day 30 of transplant, and based on the genotype, the treatment is finalized. Recently, last 2 months, the KDPI have removed Hep C as a factor in that equation, because these kidneys actually do very well. They don't need to be listed anymore in the KDPI equation. We recently looked at the newly more data about the Hep C discard, and unfortunately, there are still some increased risk based on here on 2022. They still have high risk, so still fluctuating based on the year, based on other factors such as COVID-19. So I will stop here for a second, see if you have any questions about using these kidneys from Hep C donors. All right. So we'll move to the last part of the presentation, talking about more hot topic about kidneys from donors with COVID-19. As you know, COVID-19 have changed the landscape of transplant in 2022. So in our center, we stopped the living kidney program for around 3 to 4 months. Resulted in significant decrease of the deceased donor program. We have a quite decrease in numbers, and a lot of kidneys were discarded. However, there have been no data that show that the COVID-19 being transmitted by kidney transplant. There have been reports about lung transplant, which is the main host for the virus, but there have been no data showing that if you get a kidney from COVID-19 donor, that this disease will be transmitted to the recipient. So we'll look at the outcomes and discard of these kidneys as a possible option for decreasing the shortage of the kidneys that we have. So we published this, I think last year or the year before, in terms of the donors with COVID-19, looking at the discard and outcomes of these kidneys. The question was whether these kidneys provide good kidney survival, what's the mortality, and what's the discard of these kidneys. So retrospective study, US data included around 50,000 patients from March 2020 till March 2023. We divided patients into 3 groups, one with NAT negative, so they have no COVID-19. The second group was NAT positive within 7 days of procurement, and we're going to call them active COVID-19, and NAT positive more than 7 days, we're going to call them recent COVID-19. So we have 3 groups here, and outcome of the kidney allograft quite similar at the 3-year follow-up between the 3 groups. In terms of multivariate analysis here, we are looking at all-cause kidney graft failure, comparing to COVID-19 negative. The active COVID-19 positive did not increase the risk of graft failure or patient death. Similarly, with resolved COVID-19 did not increase the risk of patient death or graft failure. So these kidneys did not impact outcomes. However, these kidneys suffer from a lot of discard. Many of these kidneys have been thrown without utilizations. Initially, in 2020, they were 11 times more likely to discard these kidneys. Later with the years, the discard ratio goes down. In 2023, we have only short we have only like few months, so we cannot tell for sure that there were no more discard. But as of 2022, there were 47 more, the risk of discard were 47 more likely to be discarded than kidneys from donors without COVID-19. We recently did this analysis looking at eGFR, so more softer outcome rather than graft failure and patient death, and the GFR was not different among these kidneys with COVID-19 positive donors. Last thing, I will end my presentation with a couple of slides about a new initiative to increase organ transplant access called IOTA. This came from the administration from the prior Trump administration rule, from the prior presidency term about increasing access to transplantation. So the idea is to maximize the use of deceased kidney transplant and decreasing rate of living donors, decrease the discard, and improve quality of these kidneys. So the centers in the U.S. were divided this year into centers that will be initially part of the IOTA before they implementing that all other centers. So it was a mandatory model, so we were included in that model of IOTA. And they have a certain model which I will show you. You either lose money or gain more money, or basically you are in the neutral zone. So they have three components. Achievements, mainly referring to the rate of transplants, how much how much volume you are able to increase year by year. So if you have a large volume, if we are doing 350 kidney transplants, and you want to increase by 10%, that's around 35 kidneys. So smaller centers may have more advantage of that criteria, the number of adult transplants increase from year to year, how much efficiency you have in your accepting some of the non-ideal kidneys, and the third one is the quality, basically graft survival at 1 year. And based on the points, if you are in neutral zone, you will not lose or gain any money. So the recipients here are the transplant centers, not necessarily the divisions or physicians. If you have points more than 60, you're gonna get incentive around 15,000 more per kidney. So if we have if our center got that all the way 100 points, that means around 3.5 extra million to our center. And if we are losing points here, and then that means 2,000 less reimbursements, so around 200,000 less for our center. So this has just been implemented, and based on the initial numbers, actually our centers comes here around 70 points. So we are getting some incentives to continue the trend that we have in terms of our volume outcomes and decreasing discard of kidneys. This is my last slide here. And this is for the CME and Mark. I will be open for any questions. Thanks.
Tarek, thanks for that great talk. I think we have time for a couple questions. And maybe I can start. So the original KDPI that had between 20 and 85% sort of as a category, it seems like a really broad range. And so is there any thought about, breaking that into different risk assessments because it's so broad?
You are right. It's so broad. The survival of these kidneys are similar. Survival of these kidneys are similar within that category. Of course, the lower the number is the better. The concern was if we are giving more labels such as less ideal or borderline ideal, that will lead to more discard of these kidneys. That's why they kept them in that category of sort of like standard to encourage more utilization of these kidneys. But that's a good thought about more labeling.
That was terrific. Thanks, Tarek. This may be a crazy question, but in part we don't HLA match our recipients at all. And we immunosuppress more, but we have great outcomes. So I'm wondering if there's ever been any exploration of looking at less HLA matching in the kidney field.
Yeah, so HLA.
Repeat the question.
Yes. So the question is about the heart transplants. They don't look at the HLA mismatches. They give less induction. They give, I think, only steroids. Whereas with the kidney transplantation, we give more induction and we look at the HLA mismatches. So in transplant data have been shown that if you have 6 HLA mismatches, your risk of rejection will be higher than the 0 antigen mismatch. So despite that, we do perform 6 HLA mismatches. So we don't decline offers based only on that fact. We may give them more immunosuppressive medications. We may keep tacrolimus in a higher range, but we don't decline the offers. Now, in the allocation system, if it happens that the kidney is coming from a donor with 0 antigen mismatch to the recipient, that recipient will go up all the way to the top of the list.
Great presentation.
Thank you.
One of the things that, concern about some bias experienced by African Americans with straight transplantation. So I've had patients who tell me, the doctor also called and said, I'm going to get a kidney, but it seems to be one of those used kidneys, real quality. Are they providing those kidneys to patients like me because we're African American? That's out there. And so, obviously, our truth with the data is pretty remarkable. So, the FASN has a initiative, long-term initiative, and we're out there using your data to show these outcomes are great. But it's just issue to work. There is an element of modesty resistance as we actually try to get this data out into the public. I just want to commend you for giving us opportunities and data to show that you're getting a kidney which is performing just as well. I just want to
Sure. So Dr. Ross is asking about possible discrimination that could happen for candidates who are African American, that they may get more non-ideal kidneys, more marginal kidneys, if you want to say, compared to the other ethnicities. Now, the GFR equation, as you may know, it included race as a factor. And that did discriminate for the waiting time for patients with African American. They were late to be added to the waiting list based on the GFR equation, because the GFR has to be less than 20 to be added to the waiting list. In 2024, they started that program that all African American patients, their waiting time, they will go back with the data looking at any creatinine with a new GFR less than 20 to be added to the waiting list, even if they have not been evaluated by our center at that time. So we applied that. Actually, we were one of the first few centers to apply that. And we did transplant to a good portion of our African American patients on the waiting list. During a certain period of time, the transplant floor, majority of the patients actually were African American, benefiting from that change of rule, that you go back with your waiting time till your GFR 20, even if we were not evaluated by that time, which is not applied to white recipients. Now, but your point regarding providing non-ideal kidneys to African American candidates, I don't think, at least in our centers and the centers that I know, I don't think this is, because this is in practice, because this is out of our control, basically. It's basically, you have donors with kidneys and you have patients on the waiting list and the match system. So we don't have much individualized decisions like, let's take this kidney, skip that patient, and let's give it to the 4th patient on the waiting list. So it's less human being involved in that allocation system. It could happen. It may happen. I agree.
It's just perception.
Yeah.
We can address that perception.
No, I agree with you, boy. And even for living donations, unfortunately, the African American have less living recipients. So they are less likely to have living donors compared to the white. And there are some concerns about health issues for the donors compared to the other ethnicities based on some historic issues with prior stories. Thanks for the question.
You mentioned that it took us like a year to arrange the funding for the antiviral therapy. We have a lot of resources here. What about other programs in the country? Does everyone has to sort out or lean on some form of funding or a grant, something to make it work? Or is there more of a universal national policy where someone can fund that antiviral therapy so people can get it?
Yeah. The first, probably 10, 20 centers, they have to guarantee sort of like funding in case of the insurance company is not covering the DAA therapy. But then it's become sort of like standard of practice. And the insurance have been approving all this DAA therapy post-transplantation. Now the question, could we start earlier? Could we start at day 1 and maybe give that 7-day preventive therapy to decrease the transmission from 100% to 4%? We could do that, but it's all the time that challenge with insurance approval and overall the funding for those medications. Overall, the delaying therapy till 1 month after transplant have not impacted the outcomes. So those patients did not have more resistance, did not have more liver disease, did not have lower EGFR.
Sure, thanks so much.
Thank you.